Hello and welcome to my channel. My name is Peter Abraham. I'm a registered nurse primarily in the field of hospice. If you're new to this channel, welcome. Thank you for visiting. If you like what you're seeing, if you have questions, this is a non-judgmental channel. Please comment in the comments below and I'll do my best to answer your question. And if you want to see more about what you have been seeing or are seeing, please subscribe. Today's episode, I'm going to try to keep short. It's going over the foundations for a brand new book I literally just started. For those of you who have been watching, you already know that not only am I a hospice nurse, but I'm a book author. I like writing books for my fellow hospice nurses, for holistic nurses, as well as for caregivers and family members of loved ones dealing with chronic diseases that often do turn terminal. And so before I go much further, I do like to have in every episode things I'm grateful for. And it's not just like, look at what Peter's grateful for. My encouragement to you is that throughout every single day, as often as you can, stop and think, what am I grateful for today? I do believe that builds resilience in the field of hospice, where we're dealing with death and dying on a regular basis and family dynamics. Resilience matters so much. So I find that if we have a very grateful heart, it's easier that when we get hit with those storms, that we bounce back. And speaking of storms, my wife and I moved to central Kentucky late last year. And while I am grateful that we made it through, yesterday was a mess. Yesterday evening, we were out of power for several hours. Our puppies, two of them are back there. You're seeing the portion of one. They were a mess. Um, I was praying fervently that I would not have to go to the hospital because our oldest, who is buried back there in a way, alive, not buried alive. That sounded really awful. She's still alive but not buried. She just in the pillow like she is buried. She is so afraid of storms. She ended up pawing, like I don't wear my glasses while I'm sleeping, pawing as I just opened my eyes and the next thing I know, if I'm having claws go in. Anyway, made it through the night. Power came back on. And I'm just so grateful. We did surpass 500 books sold for March. The count's still going on. We have till midnight this evening. I'm grateful whether one book sells or many. February was 595 books. So far, we're a little over 540. I don't know if we'll hit 595, but God is always in control. So we'll see. So I'm grateful for each and every one of you who is buying my books. And I'm grateful that I had the opportunity to write the introduction of my next book that I'm going to be showing you shortly. I have no idea on timelines. There are times, and this is all that I do. So I love typing, I love writing, and there are times I can complete a book, in 2 or 3 weeks or less, depending on, like, one of the books I'm going to show you did not take long just because of how thin it is. And it's tightly focused. But this is going to be my most extensive book, Hospice Clinical Pharmacology, that I'm going to be showing the introduction shortly, because I do desire to have a large number of case studies as appropriate, and make it so that we're all learning in the process. Um, so moving forward, before I give you the overview, this book, while it's going to be using multiple scholarly references that are out there, including the Beers criteria, the stop frail list, the medications appropriate index, the potentially inappropriate medication list. I'm also using as references three of the books that I have written because they already contain valuable data. There's let me get it in the right focus, medication reconciliation in hospice care. So this is mainly looking at deprescribing, reducing polypharmacy, And how do you work with the providers to deprescribe, as well as how do you educate the family and the patient, depending on how cognitively able the patient's able to understand. You don't need to be on this. We need to work you off of this and to get their buy-in. So this book works on that focus, and it looks at the Beers criteria. And I really, really enjoy the European stop-start STOPP/start framework. I believe they have an edge on how we handle things compared to the Beers criteria in the U.S. But it's going to be using this as one of the references for the book. When I said books that I could write, I wrote quickly. This is one of them, Whispers of Time. So it's like a Barbara Carnes style book in terms, if you are familiar with her booklets, they're very thin. They don't take a lot of time to write if you're focused. And I was like watching yesterday an interview with Stephen King. I am not Stephen King. I'm not claiming to be to have his type of creativity. But what I enjoyed when I was watching an interview with him is he talked about like almost going into a translate state when he's writing, and just being that tightly focused. So this book just focuses on the timelines that we could recognize as hospice nurses to know how long somebody has, and then a deeper dive into that framework is the art of hospice prognosis. And so why these two books matter in reference to the new book that I'm writing is that when we look at clinical pharmacology, part of the picture is how much longer does this patient have to live? Part of the discussions we probably all have had, and if you haven't, you will, is that hospice patient that just lost their gag reflex and the family wants you to start an antibiotic. We've all been there. And if you haven't, you will in time. We've all been there. So the prognosis matters as part of the picture. So I want to keep this tightly focused as to your time as well. So I'm gonna now go into the overview of just the brief introduction, and then we'll come back for the outro. So thank you, and we'll move forward momentarily. This new book for hospice nurses is tightly focused on clinical pharmacology in the last 6 months of life. It's looking at the hospice philosophy of comfort for the patient rather than prolonging life, rather than causing any type of suffering by, well, if we do fluid restrictions or we do diet restrictions, or even in the case of if we add this drug, we can add something other than comfort. So we're looking at a comfort first approach, a prognosis decision approach. And with the books that I write, I try very hard to include clinical examples, even in the introduction where appropriate. We have to take into account ethics as we're looking at our decision making. We have patient autonomy. So if the patient says, I don't want to take this med, we need to respect that and advocate for that. If a provider is pushing it and they don't want to take it, we need to work with the provider to advocate for the patient. And at the bottom line, this is one area where we do have to get our feet into the fire. We will never force the patient to take a medication the patient doesn't want. Now, I know there's going to be fine print if you're dealing with terminal agitation in terms of you get the ethical of sneaking in the food and so on and so forth. That's not what we're referring to here. I do plan to have emphasis on rural hospice. So I know there are a number of you out there that work in inpatient settings. Some of you are GIP in the hospital. Some of you are predominantly in facilities. But I also want to pay careful attention to those of us like myself. This is the background I have. Where you're a rural hospice nurse, we don't always have access to the lab values. And then where we're making these phone calls to the providers, we need to go based on what we're seeing out there in the field. There's going to be an intersection of pharmacology and the hospice philosophy. And when we talk about our role as a hospice nurse, it's patient-centered focus, back to the prognosis, risk versus benefits. And every time that we have an opportunity to de-prescribe a med, we should be involved in de-prescribing medications. Keeping an eye on red flags. One of the things I plan to do extensively in this book, when I mentioned having case studies throughout the different chapters, is I'm looking at this book as an educational tool for you, for me as a writer. I'm researching and writing, that we're going to be looking at two goals. Two goals. So the first goal is we're out there in the field and we believe there needs to be a change. Either it's a new medication added, a medication deprescribed, a dosing change, or switching from one medication to another. For example, evidence-based is that inhalers are not as effective as nebulizers, so we want to make that change. So we need to be able to communicate that effectively. But then the other part of the equation is we, especially in facilities, we go and we're getting notified. One of the providers, it could be a facility provider versus our medical director, they called in and they gave a brand new order. And if that order goes against the patient goals, the goals of comfort, the hospice philosophy, if it's way beyond the prognosis, some things we just don't feel this is in the best interest of the patient. When I say we don't feel, I'm not talking about the warm, fuzzy feelings. I'm talking about our nursing gut. We need to be advocating for our patient from that perspective. So with that, and you may have heard about this from, if any of you come from the hospital setting, I come from cardiology, medical surgical, you may be familiar with the team steps approach. It's a whole framework of how to communicate effectively with your team. It's not just the S-bar, which all of us as nurses should know rather intimately, but it's also the cuss. We're not talking about cursing, but the I have a concern, we have an unsafe situation, I'm uncomfortable about a safety issue, we need to stop and think, please, and let's go over. There's also the DESC for complex situations, where I'm going to describe a situation, express my concerns, suggest an alternative, and go over the consequences if nobody's listening to us. So this book will be going over how to properly communicate with providers, whether we're the one reaching out or they've already reached out and gave orders that we're not comfortable following through with. This is the first draft. I've not formatted the tables yet in terms of whether I'm going to have boxes and borders and whatnot around them. But throughout this introduction, throughout other chapters, there will be clinical examples going through how do you apply this. And I do plan to have appendices with checklists and so on. For example, this talks about creating pocket reference cards. Well, I do plan to have, as part of the appendices, here is the team step framework. Here's an S-bar template. Here's a CU, I have to do the other S on that. Here's the DESC template. And then focusing on the scope of this book. Most of you who have read the books that I've written, you know that I try to stay tightly focused with my book. I don't try to write the art of War and Peace, and here's everything about case management. I have a book on visit planning. I have a book on what when you're in the visit, how to make sure it's a complete visit. So this book is going to be focused tightly on the clinical pharmacology and hospice from the perspective of you, the nurse, reaching out for change, or you reaching out to talk to a provider about, I don't think we should be going down this road. And hopefully throughout all of this, we're all going to benefit. And as I've shared in a previous episode, while there are books I write based on what I believe to be market demand and how I might earn out of this, I believe hospice is a service and what I do is a service. So if just one of you were to buy this book when it's eventually published and you were to use this book to benefit your patients, that would have been enough to benefit me. I would have blessed you. You would have blessed your patients. It's paying it forward. So thank you so much. And then we'll take it from there. The books that I've written are done so based on one or more hospice nurses saying, I wish we had more information on XYZ. And they may not word it that way. I do know there are times where, for example, Tanya Frazier wrote back and reached out directly. I wish we had a book about teaching hospice nurses. The answer is not always throw on oxygen. Talking about nasal cannula external oxygen. Clinical pathophysiology was more of seeing that there's not enough information out there as it relates for hospice application. Or we get into the first book that I ever wrote that's still the number one bestseller is the documentation book. And that just seeing the cry out from my fellow hospice nurses, how do I write my narratives in the correct way to reduce audits, to be more compliant, and to maintain eligibility? So I'm putting that out there because I would like to encourage you that if you are out there in the field and say, I wish there was more information about XYZ, and maybe it's not a book, maybe there needs to be an article that would just help you understand that better. Please reach out to me. I love research. I'm a geek. I don't mind drilling down deep. And to give you an example of that before I end speaking, is one of my Facebook friends, she is dealing with a very rare form of cancer, also has chronic anemia, antibiotic resistant UTI, asked a question about chronic anemia. And rather than writing a book on chronic anemia, I have an article that's going to be coming out on Friday, April 4th on chronic anemia. So I love writing, I love researching, and I like helping others to be more aware of certain topics as it relates to healthcare. And for me, particularly chronic illness, terminal illness, my fellow hospice nurses, those of us who like thinking holistically, not everything's a pill. So part of this clinical pharmacology for hospice nurses will be looking at, is there a non-pharm method that we can recommend as part of the care plan? So I'll end there. Thank you so much for your time, and God bless.